as Dr. Chhavi Gupta starts, can we have Dr. Mehir Kothari on the other? Yeah. Yeah, Dr. Chhavi is going, she is going to talk on novel and inexpensive training model for teaching basic steps of oculoplastic surgery.
Good morning, everyone. Thank you for this opportunity. And just like to introduce my topic. So we all know that ophthalmic surgical training has a very steep learning curve, and we require large numbers for increasing the stepwise surgical competence. And we had Halstead's model, who was from John Hopkins, who said that see one, do one, teach one. But here we have the patient safety, which is at risk. There are cadavers, but they are limited. They are bound by ethical concerns. And we have synthetic models and simulators, but they can be expensive and inaccessible. So for ophthalmology residents and ophthalmologists proficient at some must-know oculoplasty procedures, we wanted to develop a tool to assess the utility of pig heads as a potential surgical training model for surgically naive trainees for practicing steps of common oculoplastic procedures which are a part of the NBE curriculum, like upper lid entropion surgery, evisceration plus minus implant, and lid margin tear repair. So the methodology was hands-on training session which was held using pig heads in a controlled wet lab environment. We procured the pig head, established workstations, had didactic lectures explaining and showing the videos of the surgical steps which were broken down, and step-by-step guidance and supervision by the expert oculoplasty surgeons were given to the trainees. So I'll be talking about the surgical steps. The photos that you can see above are actually the human photos, and down below you can see how that can be achieved in the pig models as well. So all the surgeries were divided into their key steps, and they were achieved on the pig models. So this was entropion correction with margin rotation, where you apply the traction sutures, give incision, do subtarsal dissection, and put everting sutures. And this was the outcome on the pig model that could be achieved. And similarly, evisceration plus minus implant was done, and it could be nicely mimicked on the pig model, and even an implant could be placed in the intraconal space. Coming to the lid margin repair, here also it could be mimicked, where you give an incision on the lid margin, you help the trainees identify the gray line, help oppose the lid margin, and practice the lid margin forming sutures and the skin sutures. So to assess their performance in the workshop, we had a subjective assessment which was based on a Likert scale. There was a questionnaire for the faculty to evaluate the trainees, 3-point scale, whether they could perform the step, had difficulty, or could not perform at all. And similarly for trainees, we had for tissue feel, how they felt that their skills improved, and about the surgical steps. Also, for objective assessment, we developed a competency-based surgical assessment rubric specifically for entropion correction with marginal rotation, which was vetted and validated. And these had 5 key steps of surgery and 5 global indices, which are based on the OSCAR system. So this is based on the modified Rifus model and has numerical tracking system, descriptive narratives, and scores for performances. And eventually, this surgery was then carried out by some of the selected workshop candidates in the OT within 2 weeks on real patient and evaluated using the same rubric. So this is actually the rubric that we had developed and that was used. And we had about 18 participants, which comprised of residents and ophthalmologists. And about majority of the participants had never performed these surgeries independently. So coming to the subjective scoring, we could see that majority could do the steps, and they had some difficulty in passing the horizontal everting sutures, but that could be managed with some assistance by the faculty. And similarly, the performance was evaluated for each specific step of surgery, for evisceration plus minus implant as well, and similarly for lid tear repair as well. So you can see that majority of the participants were able to perform the steps of surgery on the pig model. And when we took the assessment from the trainee side, they felt that the texture and tissue maneuvering was similar to the human eye. They felt that the practice on the head would make their surgeries more helpful on the human eye, and they had a better understanding and confidence of the surgical steps. For the objective scoring, that is the rubric, in the validation process, we achieved a score of 4. For the participants, it was about 3. And when it was taken in the OT, it was 4 again. So this helped when the participants actually performed these surgeries on the patient, they could focus more on points like hemostasis, patient cooperation, and they could overcome the apprehension. So usually what is an ideal model for surgical training? It should be available, it should be easy to dispose, inexpensive, and should be free from disease transmission. PIC model has priorly been used in selective oculoplasty surgeries, some glaucoma and cataract surgery training, but this was the first study that has utilized it over multiple surgeries. The advantages are it is available and affordable, and it is otherwise a waste to the arbiter. And they have similarities to the human eye, which I will just show in the next slide. And this was also reflected from our responses from the participants. So human eye is, compared to the human eye, upper tarsus is a bit smaller, conjunctivine skin is thicker, it has more fat, no bony orbit, puncta is present only in the upper lid, and also other features. There were some difficulties which were present, but they were managed with a larger cutting needle or performing prior canthotomy on the pig eyes. So in conclusion, it is an affordable, useful, achievable model in a resource-constrained training environment recommended for early training, and all the rubrics once formed, they will have a future application. Thank you.